Welcome,
Okay.
folks. Love to welcome you to our ongoing trauma series with Dr. Shurtleff. Today is going to be a review of level one field trauma cases. Have some very interesting topics in here. Just for housekeeping purposes, if you could remember to put your name in the chat with your license number. If you're from out of state, please email me so I can make sure you get a certificate. There'll be an evaluation at the end. That's your opportunity to tell us how we did and give us some feedback, which we always appreciate. And I will give the floor to Dr. Shurtleff.
Hi, everyone. Um, Glad to be back with you this month. Can't believe it's been a month already, but here we are. Um, Thank you for your time. For those of you who haven't seen one of these or who haven't met personally, my name is Dr. Shurtleff. I'm the EMS liaison for the trauma surgery service at Maine Medical Center. I'm one of the trauma surgeons here. Um, just a quick plug, if for the chiefs or actually for all the crews out there, if there are sort of immediate or more timely requests for feedback, please forward those through your chiefs to me and I can respond via phone to the chief directly. That's just how our information sharing guidelines are, protocols are. Um, and that to those who have already started sending me stuff, all apologies if there has not been a response yet. It's been very busy here, and I'm working on getting back to all of y'all. So hopefully within the next couple of days, you'll be hearing from me. So without further ado, these are a couple of cases that I think were good illustrations of critically injured patients and how we handle these injuries, both from a pre-hospital standpoint and then also through the initial presentation in the hospital and then on from there. The first is a critical polytrauma after a motorcycle collision, and then the next is a gunshot to the chest. So we'll do this periodically. We'll do what we think are instructive case reviews that I think can help illustrate important points about both pre-hospital care and then also kind of what happens when the patient makes it to us. And other times, well, there are some lectures that we'll do that are more of a sort of regimented review of protocols and how our mainstay protocols uh, integrate with different cases and different presentations of different things. So let's go to the next slide, Eric. So this was a level one field trauma, the helmeted motorcycle crash at unknown speeds. On scene, the patient was combated with the GCS of 8, which, at that level, we're all thinking about the rhyme GCS 8 innovate, and especially with an unknown, when you don't know in the field, obviously the safest thing for this patient is to control the airway and oxygenate them. He was unable to respond to command, and the length of loss of consciousness was unknown. He presented to Maine Medical Center. He was hemodynamically stable with tachycardia in the 1 teens. So if you're thinking about grades of shock, this is grade 2. We're not seeing any changes in the blood pressure, but he's persistently tachycardic. He is in significant respiratory distress and oxygenation, despite the best attempts in the field with field methods, was between 70 and 80% on supplemental oxygen. Next slide. Oh, and also I forgot to say this at the outset. If you have some questions, either put them, type them in, or and after a few slides we'll pause and then we can answer those. I'm not tech savvy enough to do that at the same time while I'm talking, but we'll pause here in a few slides and go over questions. So if you have them, just put them in the sidebar and the messages, and we'll get to them. So the patient was promptly intubated on presentation. CT scan was obtained, and these were his injuries. left posterior temporal occipital hemorrhage, subarachnoid hemorrhage, frontal calvarial and frontal sinus fractures, um, right orbital superior and medial wall fractures, right eyebrow laceration, displaced common fractures of a distal radius and ulna, displaced fractures of the right scapula, right acetabular fracture, adjacent soft tissue hemorrhage, focal aortic dissection, the celiac artery involving upper abdominal aorta, and the bilateral pulmonary contusions. Probably the most significant injuries, just in terms of his overall course in the hospital, were these pulmonary contusions, and the and the head injury. And so we'll go a little bit more in depth in discussing those types of injuries here in a minute. Let's go next slide. So in the emergency department, this is the emergency doc's note. He received maximum support and pre-oxygenation with high flow nasal cannula, as well as an armor breather. So every way we could deliver, we did. He was pre-oxygenated, and then RSI showed hyperangulated geometry, which means probably why the team was struggling to oxygenate him in the field. Just his anatomy made that difficult. They maintained C-spine stabilization, and they were able to obtain a view. They got a tube in. They confirmed, and he did have a transient hypoxic episode, but then once the tube was in and they were able to bag him back up, he remained over the 90s. We know that for traumatic brain injury, what is critical to avoid secondary anoxic brain injury, is to maintain SATs over 90%. We know that in a severe brain injury, a single episode below 90% can increase mortality 4 times. That's a really significant finding. And so that's part of why the state protocol calls for, really conscientious oxygenation of all brain injured patients. I would just say get everybody on a nasal cannula. Having some reserve can always help, even if it's a less severe injury. But definitely with anyone GCS 8 or less, or anyone even in the range um, between 8 and 14, those patients really benefit from oxygenation and having reserve during transport. Next slide. So these are some of the worst. Can you guys see my cursor, Eric? Can you see the cursor? Oh, he's got a cursor. Okay. Can we put the cursor on the white stuff on that lung on the right? Right lung. That's the one. So those are pulmonary contusions. Those are bad. Those are very bad. This was a younger patient. And so a couple of interesting things to talk about here. Younger folks, especially in their early 20s and teens, and definitely children, they do not have fully ossified skeleton. So what happens with ribs is that they bend, they don't break. And so there's a higher energy of force that's transferred to the lung directly, whereas with an ossified skeleton, the fracture hits the rib and the rib is stiff and it actually absorbs more of the force before it fractures. It's kind of a funny concept to think about, but it bears out. Some of the worst pulmonary contusions I've ever seen, and some of the most like refractory hypoxia I've seen, were from contusions and not from like a flail chest or what you typically think of would do it. So actually contusions are really bad, and the reason for that is that this is an intrapulmonary shunt here. And by that I mean we're trying to ventilate this space, but we're certainly not exchanging any gas in that bruised tissue. It's essentially just a giant lung bruise where there's no gas exchange happening, even if the airways are open. And so what happens is the body shifts the perfusion to the unaffected side, but you can see he's got bilateral contusions here. And so there really wasn't a hole. That's why his oxygenation was so precarious. And so you get this combination with a brain injured patient that has pulmonary contusions. You can see how important some sort of reserve is in this patient. But thankfully, once he was intubated and we were able to clear with bronchoscopy and get and optimize his ventilator status, we kind of things were able to level off. We were able to get things leveled off. Next slide. That's just another view of the contusions. I don't show the aortic dissection. It was very small, and I don't think we did anything from a treatment standpoint other than aspirin. But again, you can see here, right, where he's hitting the ground off the bike, or if he hit the handlebars. You can see all that bruising along the anterior aspect of the ribs. The other reason that I try to do as many case reviews as I can is that I think there's a lot of benefit of going over images, and unfortunately, y'all generally don't have time to see this stuff in real time in the CT scanner. So I really try to find interesting things so that there's some sort of illustration and correlation for you, because in the field you don't get the benefit of the CT scanner, which we lovingly call the donut of truth. So it's much easier to do my job in many ways than it is to do yours. Next slide. But this is what's going on. If you have a hypoxic patient that doesn't clearly have flail chest and has lung sounds, but you don't think you have a pneumo, that is a major cause of hypoxia in severe blunt chest injury. On the left here, you can see that's a pretty gnarly posterior acetabular fracture that basically the ball, the femur got driven straight backwards into the pelvis there and broke that open, which required fixation. And then you can see here on the brain, on that right CT image, you can see that there is what we call some loss of gray-white interface and subarachnoid hemorrhage. Yep, there's the subarachnoid, and then the ventricles are tight, but they are open. But there is what we call there isn't like there isn't like a crisp line between the gray and white matter, and that's indicative of swelling, which is what we're seeing here. So that's typical. Two things interesting about a deceleration injury like this: one, diffuse axonal injury, which occurs right at the gray-white interface, is where the which is where the axon is basically transmitting signals from the cortex into the midbrain. That shears because those two parts of the brain are different density, and so with an abrupt deceleration injury into something that is not moving, will cause that. And we see that a lot with high-speed motorcycle collisions, snowmobiles, motor vehicle collisions as well, but tend to see a lot of that in motorcycles, mostly because the patients are getting launched and then hitting something, and same thing with snowmobiles. So that is it's not the most well-defined clinical entity, diffuse axonal injury. Some people, it'll look terrible and they'll be fine and they'll recover. Some people, it doesn't look all that bad and they never recover. So it's always a little bit of a question which way the DAI will go. In fact, MRI is not really it's not really prognostic or definitive before 72 hours, and even at that time, a subsequent MRI may overrule what you found on your earlier imaging. So it's a strange phenomenon that we see in deceleration injury, not infrequently, and it oftentimes takes a while to resolve. But thankfully, with younger patients, they're very plastic and they can tolerate a lot of this kind of thing. This happens to a 60-year-old. This is probably a different story. Next slide. So his hospital course is as follows: went to the ICU. He developed a delayed pneumothorax on the left, which was decompressed by chest tube thoracotomy. Ultimately, that tube was removed. The patient recovered well. His neurologic status improved. He was successfully extubated after the chest tube was placed. You'll know I don't know if you want to kind of think back to those initial CTs, but there was no air at all, in that space. So it was sort of unclear from reviewing his chart how exactly the pneumo developed in delayed fashion, but it certainly does happen. It's more, people that we have to do higher PEEP settings on are more prone, but there's no pneumothorax there initially, but it certainly does happen with traumatic injuries. Um, so on hospital day one, the left chest tube was placed, the eyebrow laceration was repaired, and once he was oxygenated and kind of through the initial sort of physiologic shock to the system. It wasn't true shock, but once he was through the initial physiologic insult of the injury, his brain his brain turned back on and he started responding appropriately and was able to be extubated. He could protect his airway. He was responding to commands. So a really rapid turnaround from that initial scan and from his initial presentation, where in the field he was obtunded and needed airway management. 3 days later, his wrist was fixed. They basically did everything. They did close treatment of his scapular body, and then they also fixed the acetabulum. So he got all three ortho procedures in one fell swoop. Next slide. Neurosurgery was initially consulted for his traumatic brain injury, overall managed non-operatively, and he fully recovered his pre-injury neurologic status at the time of discharge. Vascular surgery took a look at his aortic injury, and he was put on aspirin. And generally, with these smaller tears, grade 1s and 2s, the aorta will actually heal and remodel. And as long as that's what they see when they repeat the CTA at a month, then it's no harm, no foul. Higher grade injuries, grade 3s and 4s, get a stent, and a grade 3 injury is where the tear has an obvious separation and hematoma within the lumen. So you're seeing the tear is open, and there may or may not be some formation of what's called a pseudoaneurysm, and then a grade 4 is where that pseudoaneurysm is present, or else it's actually leaking outside the aorta. So those are obviously much more severe injuries, but certainly this guy's mechanism would make us concerned for that, and so we order a higher level CT scan for someone like this than we would for somebody who just fell. Plastic surgery looked at him for his facial fractures, and those healed without an operation after they repaired his eyelid laceration. And then the orthopedic surgeons fixed the wrist, the scapula, and the hip. And young, healthy patient discharged 6 days post-injury to home with some extra physical therapy help. Just want to pause there. Are there any questions about this case? Thoughts, comments?
No comments yet.
Okay. Well, if you think of something, feel free. Let's move on to the next case. And then just a few things just to highlight what's important here in terms of what is life-saving for this patient when you find a motorcycle collision with ejection in an obtunded patient with obvious blunt chest trauma, and a threatened airway with hypoxia. Probably the most well supported by evidence life-saving measure is to get the patient into an ambulance and to a trauma center as rapidly as possible. That's supported by level 1 evidence, meta-analyses. Lots of studies have been given to what can save patients, and time and again, this is the number one life-saving measure, is minimizing seat and time and rapid transport. In this patient's case, early scene notification was implemented. This helps us mobilize resources. So if you got somebody that's this injured, um, please give a call as you're coming in. That lets us mobilize blood bank, ORs if needed. It gets the airway team ready to go as soon as you arrive. And we have everything, all the resources that we can bring to bear for a patient like this. We can have them ready and waiting when you all get to us. Um, and I think, again, these aggressive efforts to oxygenate the patient with traumatic brain injury and blunt chest injury, um, it really can't be overemphasized. It's critically important to oxygenate brain injuries. And again, rapid transport. And those are the things. The other thing that when you come to study in terms of procedures, actually, the most important procedure to do en route is to gain IV access. As you can imagine, that expedites things once they get to the hospital, but also that allows you to give volume and give meds while you're traveling. I wouldn't delay transport in order to get IVs, but that actually has been of the studies that we've looked at recently, that one intervention actually does have survival benefit in the pre-hospital theater. Next slide. Okay, case number 2, gunshot wound to the chest. This was an adult male, status post multiple gunshot wounds to the chest. The police were the first to reach him. They applied pressure to his chest to control ongoing hemorrhage. The first responder noted the last breaths and loss of pulse and started CPR. So, the patient was breathing at the time of arrest. Um, was breathing initially when they first presented on scene. Paramedics were there rapidly soon thereafter. Once the scene was cleared, the officers were performing CPR. Chest seals were applied. Early scene notification was made. Inbound gunshot wound to the chest. Patient was lifted under stretcher. There was significant blood left on the pavement where the patient had been laying. Initial evaluation by the medics, the patient was pulseless, apneic, fixed to dilated pupils, anterior chest, 2 penetrating wounds, 2 upper abdominal wounds. Left chest wound had ongoing hemorrhage. Direct manual pressure was applied, and they dropped the hammer and got to us in as rapidly as possible from the scene where this happened. Um, Next slide. Uh, he I'm sorry. Hey Luke, I'm in the middle of giving a talk. Are you guys ready? Or Dr. Morse is available. I'm fine with him doing it too. Whatever you want to do. But yeah, give him a holler and just shoot me a text. Thanks. Sorry, I got lots going on. All right, so the patient arrived to Maine Medical Center and was getting chest compressions, which unfortunately in traumatic arrest are not effective at resuscitating. Um, what happens unfortunately is that where the injuries are, as if you get any preload back to the heart, you just continue to push blood out of those injuries. But there isn't much else that can be done other than moving the patient as rapidly as possible. So he's actively receiving compressions. There was no signs of life from presentation, but we knew that he fell in the window of there is, and I'll go into this a little more in depth here in a few slides, but there was a reasonable chance that with rapid intervention, we could have obtained spontaneous circulation again. So at any rate, these gunshots times 4 to the chest, right nipple, right lateral sternal notch, right costophrenic angle, left anterior chest wall. So bad places to be shot. Next slide. Um, this is an illustration. This is not actually the patient, but this is a useful illustration, I think, to explain and kind of describe what it is that we're trying to achieve with the ED, the resuscitative thoracotomy. If we see so when we open the chest right away in the trauma bay, this is what we're trying to get done. So the first thing we'll look at is the heart, the pericardial sac, which I didn't illustrate here. But if it's tense, we open it and release the tamponade and see if there is an injury that we can either place pressure on, um, put a Foley into, and blow up a balloon, although that's generally frowned upon now because it can worsen the injury, and or close in the ED with a stapler or a big suture. Something that can either temporize the injury so we can get them to the OR to fix it formally, or do something definitively. Lots of studies on this. Try to get Dr. Morse to give a talk. He's the trauma medical director on cardiac injury. That was a very strong clinical interest that he had. And he's published a lot on it. He'd be a great guy to kind of talk about this sort of thing with. But suffice it to say, if you can temporize it, generally stabbings, like lower velocity penetrating injury, has a higher survival rate than high velocity, for obvious reasons. Unfortunately, when a bullet gets in there, it can tend to tear things up pretty, especially when it makes it out the other side. Can cause a lot of damage that is very difficult to repair, especially left ventricular injuries. But at any rate, if there is no pericardial tamponade, then we move rapidly to cross clamping the aorta. So what you're seeing here on the right side, that purple stuff, so we kind of, let's see, Eric, can you go to the picture on, sorry, picture on the left with the cursor and hover over the lung? Yeah, that's the lung there. So what's been done here is that the lung is pulled up towards the head, and you can see down below. So if you go to the tissue, go to the aorta, you see it there. Up, yep, right there. That's aorta. This right here. Down, back down, down, down. Aorta. Up, rib. So follow that rib upward. That's aorta. The cursor's on still on the rib. Go back to the aorta. That's aorta. Right in front of his cursor, right in front of the pointer. And so what's covering that is called parietal pleura, and that, if you try to cross clamp across that, it'll slip. The clamp will slip off. That's a classic error in technique. That if you simply cross clamp across the parietal pleura, the patient will be rapidly decompensating on the way to the OR. And if you think to look, that's what you'll find, that there's no clamp on it anymore. In fact, the few of these I've gotten off the table in the ED and to the OR. That's something that we conscientiously look at while we're running to the OR, is to make sure that the clamp is still well applied. So the aortic cross clamp prevents ongoing blood loss in the abdomen, pelvis, lower extremities, and restores blood flow to the thoracic organs and brain. If there is a life-threatening injury proximal to this in the aorta, then you're gonna have a problem that needs to be fixed rapidly, sometimes in the ED. What I mean by that is if there is a significant lung injury, great vessel injury, aorta, pulmonary artery vein, subclavian, those things will need control once you cross clamp, or else you'll continue to bleed significantly. In fact, chest wall injury, the REBOA is chest injury in general, the REBOA is contraindicated for that reason. You have no way to control any of the ongoing bleeding, which you're going to pressurize by applying this clamp, because where this clamp is applied on the aorta is just at the very proximal portion of the descending aorta. So the arch goes up and comes down, and the clamp is there. So everything above that, subclavian arteries, pulmonary arteries, all of that blood, and the carotids, all of that blood supply will be pressurized now. And these patients in general are on massive transfusion with rapid infusers going, so the blood starts pouring out everywhere if you have chest injury. Next slide. But it will bring people back to life. Most of us will do this kind of more extensive exposures. This is called a clamshell thoracotomy, which is like it sounds. What you do is you cross the sternum, Eric, right above where it says internal mammary arteries, right above there. That's the sternum right there. That's been cut across with what's called a Lebsky knife, which is this funny looking device that I don't think I have an example of here in the chart, but if you can Google it. What it essentially is it's like you hold the handle up here, and then down below the handle there's this knife that extends this way. Sorry, there's a thing in the way. I can't see what I look. So there's a handle, and then where my knuckles are down here is actually a blade. And then there's a surface back here that you can strike with a mallet. And so we strike with the mallet and we come across it really around the fifth intercostal space is the spot you want to cross. And we go to the other side, and then we do a thoracotomy on the other side as well. So what this allows us to see is both lungs, the heart, the entire upper mediastinum, all of the great vessels, anything that could require control or an intervention is here. And so there's this saying that this is the unparalleled view of the entire chest, and it's true. And actually, the whole thing it seems crazy and morbid, but it's actually pretty easily closable once you're in there. We pull the chest wall back down, we do cerclage around the ribs, and we put a wire across the sternum so it heals okay. But and then obviously chest tubes, but it takes a while, but it's not a technically demanding part of the procedure, although it is kind of a amazing, wild view. So yeah, just some of the things that are labeled here. The internal mammary arteries are important because they bleed when you cross over, so you have to clamp them. If you're getting good reperfusion, the superior vena cava, receiving all the blood from the upper extremities and brain. And then you can see the innominate, which is that first branch off the aorta that splits into the right subclavian and right right common carotid. And then right behind that innominate artery is the left subclavian. Actually, there's you can't see it there. That's actually the left carotid, and then the left subclavian comes off. It's harder to see. But you can actually fix the subclavian injury from this view, which is pretty much the only way you're going to get to it rapidly in this situation. And obviously the heart is there. You can see the right lung to the right of the superior vena cava. It's screen left, patient right, sorry. And then you can also see the left lung, which is screen right, patient left, behind the heart. And so most of us will go to this view, especially if we're getting the patient back. Next slide. So this was the procedure as dictated by Dr. Turner, one of our trauma surgeons, my partners. Patient arrived critical care bay with continuous CPR initiated on scene. The pulses were absent at this time. The decision was made to open the chest, and the reason for that is I'll explain that a little bit more as we get to the next slide. The thoracotomy tray was brought expediently bedside. 10 bleed was used to open a long skin incision from the sternum down to the bed through subcutaneous tissue until the intercostal muscle was encountered in the 6th rib space. So in this case, we're cutting down with just with a scalpel all the way through the chest wall. We're not worrying about subcutaneous bleeding. The dissection was initiated through the space, most immediately evident, but it was deemed to be too low. Therefore, we moved to a more cephalad, the 5th rib space at the navel line, and that was opened fully. There was an immediate rush of blood from the chest. Finoshadow retractor is it's got 2 bars and 2 two sort of handles that go, two attachments that go into the chest, and it pulls. It has the function of spreading the chest apart, or the intercostal space. It was open. The rib space, lung was up. No signs of cardiac injury, but there was no signs of cardiac activity. I'm sorry. There was a hole through the right ventricle, so there was a high velocity penetrating injury to the right ventricle. It was very difficult to deal with. They extended the incision to the right chest to complete a clamshell to allow like full exposure of the heart. However, there was persistent, despite giving epinephrine and all these other measures, there was persistent absence of cardiac activity. So, given all of the factors and and then they were able to fully expose the heart, and there was an exceedingly large defect in the ventricle. So at that point, given that there had really been no signs of life, and they had already been working on the patient for probably 15 to 20 minutes, plus the scene time that's basically non-survivable, and they stopped the resuscitative efforts, and then the patient was closed, out of respect, and the time of death was later, was probably about 20, 30 minutes after arrival. Next slide. So here are some fairly recent things, fairly recent study published by one of the luminaries of the trauma world, Ernie Moore, Clay Cothran, and these folks are in Denver. But Ernie Moore basically was one of the kind of defining figures in trauma surgery over the last 25, 30 years. General, if he puts his name on something, people generally follow it. But anyway, this is a review of emergency department thoracotomy for critically injured patients. And this is basically the foundation of the Western Trauma Association's approach to resuscitative thoracotomy. The Eastern Association for the Surgery of Trauma, or EAST, has a slightly different approach, but in general, there's pretty good agreement between the two organizations about how this injury should be managed. Next slide. So this was a multi-center retrospective case review and litter review analysis over the last 30 years or so. ED resuscitative thoracotomy was successful in 35% of patients arriving in the ED in shock with a penetrating cardiac injury. So that's different than this patient. Arriving in shock means that you still have signs of life, you still have a pulse, you still have breathing as well. 35% penetrating cardiac. So these are probably the folks that are getting stabbed. If they're coming in with shock and signs of life, or it's a smaller caliber, low velocity wound, depends, so much depends on what it is that's actually caused the injury. For all penetrating injuries, though, that number goes down to 15%. And I think if you have an abdominal aortic injury, or you have a more, difficult to approach injury, that's part of why that number is going to go down. Patients undergoing CPR on arrival to the ED should be stratified based on the injury type, penetrating versus blunt, which we always do, and then transport time to determine whether or not a EDRT or ED resuscitative thoracotomy, to even determine whether that's just an incredibly morbid procedure that's futile, or if there is actually a chance. And in this patient's case, he was a penetrating injury with signs of life less than 15 minutes prior to presentation. So if that's your patient, there's a chance, especially in younger folks. So that's just something to kind of have in the back of your mind. Always, always, always call us and we'll guide you through this. We're always here. I guess that's probably the most important thing. Bottom line, always call early scene notification, and we'll help you down the decision tree with our ED colleagues as well. Patient outcomes relatively poor when ED resuscitative thoracotomy is done for blunt trauma. In fact, only 2% survival in patients that arrive in shock, and only 1% if they have lost vital signs en route. Next slide. So this is a very busy thing that I think all of us at some point have committed to memory in our training. But really what this boils down to are the contraindications for ED resuscitative thoracotomy. So for blunt trauma, where there have been no signs of life for greater than 5 minutes, so fixed and dilated pupils, no motor activity, no respiratory effort, no an asystole. For those patients, there is no benefit for ED resuscitative thoracotomy, and Dr. Moore, in all his infinite wisdom, argues strongly against it and calls it a frank contraindication. For penetrating trauma, this changes, and this is because we know that there is a potentially fixable cause, and the decompensation is quite different. If you have a blunt injury that is in hemorrhagic shock, you probably have a major vessel injury that is bleeding into an organ space, but it is not rapidly fixable. We know from a slide or two back that really the ones that we're saving are the low velocity cardiac injuries, or the cardiac injuries where there's a very clean defect that's fixable. So if we're talking about intra-abdominal aorta, we're talking about pelvis, we're talking about those things, these folks, depending on how decompensated their shock is, also will have problems. But for penetrating trauma, 15 minutes is the benchmark, and that's been that way since I was a resident. You could argue that if they've had no signs of life and they're asystolic for 15 minutes or greater from the presentation, then again, it's futile and shouldn't be done. I think where this gets controversial is when the patient is young and can sustain a much more deranged physiology for longer periods of time. Because everybody has a war story where they had a young person that was outside the 15 minutes that actually survived. Well, not everybody, but many trauma surgeons that have been doing it a long time do. So, but I do, in general, it is broadly accepted that 15 minutes is really like your chances of saving somebody after that are slim to none. Even with even with like a low velocity penetrating to the heart, if they've truly have had no signs of life. And that's actually where we ended up with this patient. Everything was done and initiated in terms of with the intent of saving the patient's life, but it had been far greater than 15 minutes when they terminated the resuscitation efforts, but they hadn't really recovered any sort of meaningful cardiac activity, and the defect was so large it was prohibitive to fix. So next slide. And so you can see like an overall survival is about 3% for all of the studied, and these, so you can see the centers that they were studying there in that left hand column: Denver, Detroit receiving, Johannesburg, South Africa, Los Angeles, New York, San Francisco, Seattle. So these are centers that are seeing this stuff with reasonable frequency. And with no signs of life, they were seeing about a 3% survival. So that's in presentation, loss of signs of life in less than 15 minutes, penetrating injury. The next column to the left, no vital signs, those folks, but there were some signs of life that had a higher survival rate. And then overall, if they were in shock, those folks were sort of 35% of those patients. So if you can get them here and they still have a pulse, we've got at least a 35% chance of saving a cardiac injury, a penetrating cardiac injury. So I think that's I guess the best impetus for getting them here as rapidly as possible and staying in communication with us the whole time. For penetrating in general, so that's chest, abdomen, pelvis, thigh. The survival benefit in the shock patients was less than half. You can see it's a 14% survival rate. So these folks were bleeding into a different organ space, and it wasn't a frank cardiac injury. And you can see that the ability to save those patients goes down significantly. And then for blunt, it's uniformly poor across the board. For patients in shock, it's only about 2%. No vital signs, it's 1%, and then no signs of life, it's 0. Next slide. That's it. So these are the references. The pictures come out of the ASSET course, which is something that we train the mid-level residents, the third years, and through chiefs. And we help them, learn how to make rapid exposure of all of these major vascular structures and things that can be injured. And that's just one of our training textbooks. And then the other paper here is the one I was talking about that Dr. Moore and Dr. Cothran put out. Are there any questions, comments, thoughts?
We did have a couple questions from the first patient that popped up
Sure.
afterwards.
Yeah.
One of the questions was the first patient helmeted?
I don't think so.
Okay. And the second question for the first patient is thoughts on TXA with a patient with TBI versus chest injury.
It's funny, you're just about to hear a TBI talk from Joe. I think if there is concern for hemorrhagic shock, like the patient's in shock and they have low blood pressure and you're concerned about polytrauma, then it's indicated. It is not indicated for TBI alone at this time. We 10 seconds. There's a very, it's funny, we have a really I've got to talk on this, but I don't want to steal Joe's thunder. Let's see, here we go. There are in your protocol, there are indications for giving TXA. The major contraindications are 10 seconds. Obviously, you always want to discuss with OLMC. So greater than 16, hemodynamically unstable, and per our protocols as they stand now, hemodynamically unstable is evidenced by tachycardia, hypotension, or other evidence of shock. So you could say this guy was persistent as he met criteria. And then the other major criteria is that they're less than 180 minutes from injury, which in general, you will be seeing them in that time frame. So isolated head injury, it is not indicated. So this is where it gets a little bit subtle. So if you just have a head injury, there's no other injuries, then it's not indicated. However, if you have concern for other injuries, like given the way this guy's chest looked and his pelvis, then TXA would be indicated in this patient. And we're working on kind of newer guidelines, talking with neurosurgery and these types of things. The protocol's evolving, but at any rate, that's the story on him. So that patient would benefit from TXA, and he met criteria for class 2 shock. If you're going by a heart rate elevated over 100 persistently. Does that answer it? Okay.
I would say so. We have no additional questions.
Okay.
In the chat or in the QA.
Well, thank you all very, very much. I appreciate your time. We appreciate all the work that you do, and stay tuned for Joe.
All right, folks. Have a great day, and we'll see you tomorrow at Joe's Talk.
Oh, Joe's tomorrow. I'm sorry. I thought he was later today.
That's okay.
All right. Well, thanks, y'all. Have a good one.
Thank you, Dr. Shurtleff.
You got it.